Hello, I'm Pieter Uvin. I'm a urologist from Bruges, Belgium. A year ago, we started with MiLEP procedures, which is performing laser enucleation of the prostate with small Charriere 22 instruments compared to the classical Charriere 26 or 27 instruments. MiLEP is a durable and safe procedure for patients with benign prostate obstruction, also for patients who already had a previous procedure such as TURP, Rezum, Aquablation, or even prostate embolization in their medical history. So in this video I will show 3 redo MiLEP procedures after Rezum, TURP and Aquablation. The surgical technique and material that I use are exactly the same as in a standard MiLEP. So let's move on to the first case. So here the patient underwent a Rezum procedure 3 years ago but still had voiding complaints. After a previous procedure for benign prostate obstruction, I typically use a transrectal ultrasound, a cystoscopy and urodynamics to evaluate the patient. This patient had a medium-sized prostate, a quite normal urethral and prostate inspection, and an obstructive detrusor flow pattern on urodynamics. So here I'm introducing the MiLEP resectoscope inside the urethra. And now I enter the bladder, which clearly looks trabeculated. So now I have a look at the right and the left orifice, which are safely away. So it looks like the laser fiber has not been cut in a straight manner, which is what I prefer. So that's why I do a little test shot, if you would like to call it like that, in the middle of the prostate, which will be eliminated afterwards. This is only to see if I can fire the laser fiber straight. But that was the case. So now I can immediately start the procedure, and as you see here, I cut the mucosa right at the border between the sphincter and the adenoma. So this is the creation of the so-called white line, as was described a lot by Professor Gomez Sancha. And I already tried to deepen it here a little bit in order to get easily around the prostate. As this prostate is rather small, I immediately try to make an omega incision, and I try to find the posterior plane and try to make wide movements going from the lateral left side until the lateral right side. And as you see here, actually, this is a status after Rezum procedure, but this prostate looks rather normal. It could be that the asymmetry that you see inside the prostate, with the left side lobe being a little bit bigger than the right side lobe, is caused by the Rezum, but I'm not really sure. So this is not like the cases that we see afterwards. So here I'm already quite easily developing the posterior plane. This looks quite nice. And now I'm trying to find my way on the distal point of the adenoma. So I'm making the plane posteriorly at the apical side, at the right side of the prostate. So as you see here, I'm always trying to create some tension on the fibers by positioning my instrument at the right place. So the right side is done for now. So now I move to the left side, and here I'm deepening the white line just a little bit more in order to create some mobility in the adenoma. And then I connect this with the posterior plane that was already developed, and I again try to create some tension on the adenoma to dissect in a nice anatomical way. So again and again creating tension and developing the posterior plane as much as possible. So that's done for now, and here you see the sphincter, the anterior sphincter, which is nicely preserved until now. And of course that's the goal of this procedure, or one of the goals of this procedure, to keep the mucosa on the sphincter as intact as possible. So now I'm deepening the white line, the anterior part of the white line. I'm deepening this out by cutting a few millimeters on the adenoma in order to mobilize it and in order to get around it in the next phase of the procedure. So I'm gradually moving up to the lateral right side of the adenoma in order to enucleate it as much as possible. So maybe here it's a little bit more sticky. Is this due to the previous Rezum treatment? I don't really know. But it can also be the normal variation that we see between prostates. In any case, as you see, an enucleation with MiLEP or with MiLEP is certainly perfectly possible after a Rezum. In this case, you do not really see a lot of effect of Rezum, but sometimes it's very different. Sometimes I have seen like big cavitations inside the prostate or big kystic structures in which you fall after Rezum treatment. So these things can happen. Now again, I turn back and I try to circle around the adenoma, and now I'm at the left lateral side of the prostate and I'm trying to get around it and to release the left lateral side of the adenoma. So Rezum is actually a treatment that I offer myself. All my patients, however, are getting a decent counseling about the downside of Rezum, and that is the less durable results, especially in the long term, compared to laser enucleation, which is only logical. But if a patient really wants to maximize his chances of having an antegrade ejaculation, then Rezum is a decent treatment for the right patients in the right prostates with the right bladders. So I will never do it in very large prostates, and I will not do it in patients with a decompensated bladder, for example, with a lot of diverticula or with a high post-void residual volume. So most of my patients with benign prostate obstruction that needs surgery will opt for laser enucleation. But I would say around 5% of my patients will in the end opt for a Rezum procedure, and I'm happy to provide it for them as long as I can counsel them in the right way. I think it has value in some patients who really want to preserve their ejaculation if they are aware of the downsides. And here you see me really going under the sphincter. This is the anterior apical part of the adenoma, which is now being released completely. And this is one of the more difficult steps. In smaller prostates, it's quite all right. Here it's not difficult to keep your overview, but in very large prostate, this is probably the most tricky step of the procedure. So it's very important here to try to spare the mucosa on the sphincter. So you have to cut the longitudinal fibers at the right place. And if it's impossible for you to put your instrument at the right place, then it's probably too soon that you're trying to do it there, and then you need to mobilize more. It's always a way of mobilizing and mobilizing. If you have to give too much force on your instrument, you have to stop and you have to move your instrument to another place in order to mobilize the adenoma more until you can reach the place where you really want to go. So here you see the right lateral side of the prostate that is being progressively mobilized. So I'm pulling my instrument back, which is always the thing you should do in order to get overview. You have to pull your scope back and look. And here you see the mucosa on the sphincter, which I really want to preserve. So I cut under it. As you see here, I really cut under the mucosa on the sphincter, and I mobilize the anterior apical part of the adenoma now at the right side. And this will allow me afterwards to connect this to the previous incision at the left side, and then we have a complete apical release. So now you see me working on the anterior part of the adenoma, and now I'm starting to try to connect the incision from the anterior left part to the anterior right part, as you see here, and there you saw a glimpse of the mucosa on the sphincter, which I really want to preserve. And now I cut the longitudinal fibers at 12 o'clock or between 1 and 11 o'clock in order to get a complete anterior apical release, which is almost the case. There you go. Now the apical release is more or less done. Now it is. And then I keep mobilizing the anterior part. I keep developing the plane on the anterior side until I reach the bladder fibers, which in a smaller prostate just as this one is normally very easily done. And I always try to connect this to the plane that was already developed at the right and left lateral side, and this lateral plane should be in connection with the posterior plane. So that means that we have one big circle around the adenoma. So I'm continuing the dissection until I find the longitudinal fibers on the bladder neck. So that's the so-called whale sign, which will normally pop up quite soon. So it's the longitudinal fibers that you will see that look like the mouth of a whale. And you just keep mobilizing and mobilizing, even if the plane is not really clear as it is now. The amount of mobility that you have on the adenoma after a complete apical release is so beneficial that you will be able to find your way. So just try to find these longitudinal fibers, and now they're coming up. Here you see already the bladder popping up. Black is bladder, there you see the bladder, and these are these longitudinal fibers. So we're almost there. So here is the bladder, and I'm already opening the bladder. And so as you see here, this patient does not have a lot of anterior tissue in his prostate. We're right above the anterior commissure. That's not a problem at all, but it's just something that I note. And now I will open the bladder neck for between 10 and 2 o'clock. So I try to open the bladder neck here just until 10 o'clock. I try to make a quite straight line from left till right. So I will go until 10 o'clock here, not until 9, here until 10 o'clock. Because if you go too low, maybe you can injure the orifices. So I want to find my orifices first. So now I have identified the left urethral orifice, so it's quite far away, so there's no problem. So I put my laser fiber at 6 o'clock and I circle around the bladder neck. So I cut down and I make sure that I do not injure the left urethral orifice. So again, it's there. You can have as many checks as you need in order to proceed safely. And now I try to make this kind of V-like incision. So I will medialize and mobilize the adenoma by creating this V-like incision, as you see here. Now I do the same at the right side. So that was the right orifice. And then again, I make a cut with the laser fiber at 6 o'clock. and I medialize and mobilize the adenoma with creating a V-like incision. Of course, you have to be able to mobilize the adenoma completely, so always pull your scope back and have a look. There's just a little bit of adenoma hanging there, so voila, now it's removed. And now it's almost time to enucleate the adenoma completely. It's almost completely removed. And now it's only hanging on a very small border at 6 o'clock. So we cut this and then we're done for the enucleation part. That's the right orifice. We want to make sure that we do not injure it. Yeah, that's the last fibers that is blocking the adenoma, and then we're there. Okay, the adenoma is completely removed. Now I will go for some hemostasis. So with the coagulation setting of the laser, I will check the hemostasis in order to go for a safe morcellation. So as you probably know, the disadvantage of MiLEP that the morcellation phase, that the visualization that you get during the morcellation phase is a little bit less. So here you see me making an extra bladder neck incision. That was the right side, and now that's the left side. In rather smaller prostates, I do it. I cut open the bladder neck just a little bit more in order to reduce the risk of bladder neck sclerosis and in order to end with a very nicely open prostate. So that's the last check of the hemostasis and of the orifices, and we're ready for morcellation now. So I will change my instrument, so the laser resectoscope has to go, and I will replace it for the MiLEP morcescope that you will see immediately. Of course, it's very important here to create nicely full bladder. So first you want your hemostasis completely done, you want the bladder completely full, and now you will see here the morcellator blades. So it's the Piranha wall system that I'm using, and I will start the morcellation. So here you want to have full bladder. You want that your nurses check the irrigation bags so that they are not completely empty. You want that the inflow tubes are open, that you create a high pressure inside the bladder in order to work safely, and you want that your material is working well. So regular maintenance of the morcellator blades and of the morcellator system is really important. So luckily here the adenoma is quite small, so the morcellation phase will be done soon. So as you see here, the quality of the image during morcellation is a little bit reduced compared to what we have known with classical HoLEP, but still it's certainly possible to go for a very safe and an efficient morcellation. So that's done. So let's move on to the second case. So this patient had severe voiding LUTs after a previous TURP procedure, which was done 1 year ago. So on ultrasound, he had a quite small residual prostate of around 34 grams, but on urodynamics, he had a clearly obstructive detrusor flow pattern, and he was known with a high post-void residual volume. So I did cystoscopy, and that was actually a very difficult procedure. It was an ambulatory cystoscopy, and it was very hard to enter the prostate. So there was this kind of synechia, so this adhesions inside the prostate, and there was also a narrow bladder neck. So it was quite difficult to enter with the cystoscope inside the bladder at the consultation. But finally I managed, and I saw a clearly trabeculated bladder. So the patient was finally scheduled for a redo MiLEP procedure. So here you see me introducing the MiLEP resectoscope. So here you see already a quite narrow zone at the bulbar urethra. So I think it's good that we are doing a MiLEP procedure in order to not cause strictures at the bulbar urethra. And here you see this adhesion between the right and the left lobe. So we will have to cut that. Here you see the narrow bladder neck with a lot of anterior residual tissue. So that's the right side and this is the left side. So I think it's only logical to cut this adhesion first in order to gain access to the bladder. You see a lot of residual tissue hanging anteriorly. So now it's already a little bit easier to see the bladder. So as in a lot of cases, the posterior part after TURP is quite nicely done, but the anterior part is in a lot of cases still hanging there and can be certainly obstructive, and that's also the case for the apical part. So I start the procedure actually as always. I make the white line incision on the mucosa between the adenoma and the sphincter. So I have easy access to the anterior side actually, so that allows me to deepen this incision already a little bit. So now I will enucleate the right side. As you see here, posteriorly around 6, there's not a lot of tissue still hanging there. So if I would really push it over there, probably I will have a perforation, so I will not do that. And now I cut open the bladder neck because I have very easy access over there. I go inside the bladder, have a look at the orifice. Yeah, it's very trabeculated as you see here, right? It looks like a decompensated bladder, so it's a little bit more difficult to find the orifice as well. And then I decide to continue with the enucleation. Here you see the sphincter mucosa, so I really want to preserve it over there. And I try to mobilize the lateral part of the prostate now. I create the access incision, so I cut a few millimeters on the adenoma in order to mobilize the adenoma, which will make it easier to get around it for a full apical release afterwards. So as you will see in this procedure, a laser enucleation or a MiLEP is very possible after a previous TURP, and it's also a very good option in patients with bladder decompensation. In that case, I think it's not a good idea to opt for minimally invasive procedures such as Rezum or urolift or prostate embolization. I think with decompensated bladders, the ideal treatment should be a complete enucleation. So here I'm mobilizing the right lateral adenoma. As you see here, it's a little bit more tricky to find the right plane. It looks a little bit adhesive, the adenoma, maybe due to the previous TURP, but it's certainly possible to work your way around it. So as always, I come back with my scope, I have a look, and then I decide where to go. But it's really important that you learn to create this overview by pulling your scope back and to see what's blocking the adenoma from being completely mobilized and released. So now we're going for the left lateral plane. And as always, it's very important to connect this left lateral incision with the posterior plane. So again, the visualization is a little bit reduced, probably due to some adhesion, but as you see here, the mucosa on the sphincter is still very nicely preserved, which is of course very good for his continence. So I pull my scope back. Here is the mucosa on the sphincter, and I cut on the adenoma right under the sphincter. So even if you are not in the right plane here, it's not a big thing. You just need to cut a little bit on the adenoma in order to create space to enucleate. Again, that's the sphincter. So I cut right under the sphincter on the adenoma in order to circle around it, in order to spare the mucosa, and I try to connect this incision from the right anterior side, which I am working on now, to the left anterior side. If you don't have, if you cannot go to the place where you want to be, you have to mobilize it a little bit more on another place until it you can do what you want. So I think that's a very good message. And now I have mobilized the lateral sides sufficiently, and I can work on the anterior side. And I try to connect the anterior planes in order to have a complete apical release as always. So I come back, probably this side needs a little bit of work, and there I have to cut through. So here the irrigation bag is completely empty, so without irrigation you have no visualization. So my nurse is changing it right now, and now we can proceed. And I'm almost made a complete anterior connection here. As you see, if these fibers are cut, then I have the complete connection. So here it's done. And now we can proceed in the direction of the bladder, and then most of the time the rest of the procedure will be easy. And then we continue to develop the anterior plane until we reach the bladder, which you see already there. Okay, so when we're at the bladder neck, you try to be as eccentric as possible in order to open the bladder neck as much as possible. And we open the bladder. So now we cut the bladder mucosa and we enter inside the bladder. And as always, I try to open the bladder neck from 10 o'clock until 2 o'clock before I turn my instrument. So here I'm developing until 2 o'clock. So that's a connection that has to be cut in order to mobilize it more. Okay. So now we put the fiber at 6 o'clock. We have a look at the urethric orifice. And in this tuberculated bladder, it's not so easy to find it. So in order to help with my future identification of the orifice, I will make a very subtle mucosal coagulation in order not to lose it for the rest of the procedure. That will help me identifying it more easily and faster. So I don't always do it. In fact, mostly I don't do it, but if it's quite hard to identify the orifices, I think it's a way to make this safer. Especially when morselating, lesion of the bladder right at the place of the orifice would of course be a potentially very serious complication, so you certainly want to avoid that. So when I see orifices that are far away from the bladder neck, I think in myself that it's safe concerning the enucleation, but potentially dangerous concerning the morcellation phase. So that's maybe something that you have to take into account. So the enucleation here is completely done. So now I go for the hemostasis phase, and here I cut these last edematous remains. But this looks very nice. So in order to save some time, I did not include the morcellation of the second and the third case, because that's not the most interesting phase of the procedure, although it's very important to do this safely. But I skipped this in order to keep the total length of the video acceptable. So I just try to smoothen the area here a little bit more. This really should be the last BPO procedure that this patient gets in his life. And as you see here, I open up the bladder neck just a little bit more. And then we're almost done and ready for morcellation. Maybe just a little bit of hemostasis there. The sphincter looks very nicely preserved, so that's good. And then the last bit of hemostasis. And opening of the bladder neck. So that's good. Looks nice. So now's the morcellation phase, but as I told you, I did not include this in the video. And this brings us to the third and last redo MiLEP case. This patient had persisting severe voiding LUTs and a high post-void residual volume after an aquablation procedure 2 years ago. So on ultrasound, he had a residual prostate volume of around 50 grams. We tried to do urodynamics, but it failed because we could not introduce the catheter inside the bladder. And ambulatory cystoscopy showed us the reason why, because there was residual edematous tissue which looked a little bit elevated on cystoscopy, and also anteriorly there was residual edematous tissue. So we discussed the treatment options with the patient, and finally we went for a redo MiLEP procedure after an aquablation which was done in another center. So here you see the laser fiber inside the bladder, and you see the elevated residual tissue, which allows you to understand why urodynamic investigation was not possible. It's not unlogical that the catheter blocks there, where the laser is pointing to now. And then we start the procedure by making the mucosal incision on the border between the adenoma and the sphincter, as always. The mobility is quite good, so we deepen out this incision already a little bit, and we make already an omega incision around the verumontanum while mobilizing the adenoma a little bit more. So you will see in this procedure, although there is clearly a residual adenomatous tissue also posteriorly, that the prostatic capsule becomes very, very thin. So it's not the most easy enucleation, although it was certainly possible, as you will see, but it was not so easy because it becomes very thin. You see it already there. It's not so easy to identify the posterior plane. So this was the first time that I did a laser enucleation after an aquablation procedure. Aquablation is a procedure that is not being done so frequently, at least not in the Netherlands and Belgium. So I try to be quite careful here, although I also wanted to deobstruct the patient completely. As I explained, we did not have urodynamic investigations available, but for sure the patient had a high post-void residual volume, so I think that he needed a complete deobstruction, and I really wanted this BPO procedure to be the last one of his life. So here I'm mobilizing the lateral right side of the prostate and working my way to the anterior part. So as you see there, the bladder neck is quite narrow, so we will try to open the bladder neck as eccentric as possible, as always. And here I'm trying to be a little bit careful at the posterior side because it looks so thin, so fragile. So if you're not, if you feel you have to be careful at a certain spot, in most cases it's a good idea to avoid this place in the beginning and try to get more mobilization in other parts in which you feel safe, and then come back in a later part of the procedure, because if you get more mobilization in other parts of the adenoma, the difficult fragile part will become more easy and it will be easier to mobilize it. So I do not offer aquablation myself. I do offer Rezum and also sometimes prostate embolization, which is, well, in my hospital, of course, done by the interventional radiologists. But most patients are best served, in my opinion, with laser enucleation. And if I have a patient who really comes to me to preserve his sexual function, most of these patients, well, they actually only need a clear explanation about the difference between sexual function and ejaculatory function. And if they know that they will preserve their erectile function, if they know that they will preserve their orgasm, well, in most cases it's not really necessary to opt for a minimally invasive surgical technique. But of course, in the end, it's the patient who has to decide. So here I'm developing the anterior plane, making my way to the bladder, as always. So this is a connection that still has to be cut, and then we will reach the bladder quite soon, as you will see. So I'm a little bit in a double plane here, so I correct it a little bit, and I choose the most eccentric plane at the bladder neck. So the deepest plane, and that allows me to circle around the prostate completely and to remove as much as possible of the prostate. So I'm almost at the bladder here. As you see, the longitudinal fibers are starting to show themselves. But before really opening the bladder, it's always a good idea to see what you can do of mobilization before opening the bladder. Because if you open the bladder, you lose some of the advantages of an en bloc enucleation, such as reduced irrigation volume such as a good hemostasis and a good overview of the anatomy of the prostate. So, of course, there's a certain moment where you have to open the bladder, or you cannot finish the procedure, of course, but you shouldn't be. It should not be the goal to open the bladder as soon as possible. So now I open the bladder mucosa at 12 o'clock, and I'm checking if my mobilization everywhere is sufficient before opening it from 10 until 2. So I'm mobilizing it here just a little bit more. And I'm already medializing the adenoma here. This is like the start of the V-like incision that I will create afterwards. Everything needs to be mobilized anyway, of course. Okay, so the bladder there is open as well. I do the same at the other side. So here it's quite thin. It's not so easy to find the right plane there. So most of the times I stay away then, and I mobilize the rest, and I come back in a later phase. If there's an easy, difficult part, then I will move away from it. I will mobilize the rest around it, and then come back. So I pull my scope back and I see what I have to do. So here there's a little bit of mobilization here at the posterior plane that has to be done. I stayed away from it before because I had a feeling that it was so thin, so fragile. But of course, there's a certain moment where you have to go for it. So you see again, so the very fragile prostatic capsule. Maybe this is due to the aquablation procedure, but it can also be caused by other conditions such as prostate inflammation. So as you see, I'm trying to aim my laser fiber a little bit more on the adenoma as what I would do normally. It's because, again, I have the feeling that the prostatic capsule is so fragile, so try to be a little bit more on the safe side. And I try to mobilize it very gently, very safely, to avoid to have a big capsular perforation in the end of the procedure. So I have already a very good mobilization over there. You see the bladder popping up there, so I have a very good overview, and I know where I have to aim. So again, I try to aim a little bit more on the adenoma because I feel that it's fragile, I feel that it's very thin. See me do it here. Okay, so that's a good mobilization at the left side. So now I know what I have to connect. So this is the zone where I was a little bit in doubt, where I had to cut. So I worked my way around it from the right side. I did the same from the left side, and now I'm able to connect these incisions, and very gently aiming the laser fiber a little bit more on the adenoma is what I normally do. I try to make my way on the posterior plane. And always very gently lifting the adenoma in order to create tension, in order to create traction, to go for a very anatomical and safe dissection. So now I really maximized the dissection that I can do before open the bladder, and now of course it's time to open the bladder, so I cut it between 10 and 2 o'clock as always. And then I have a look inside the bladder to check for the urethral orifices. I know where they are, and now I can very safely dissect my way down and create this V-like incision. So I'm medializing the adenoma just a little bit more. Again, it becomes very thin there, so try to lift it and aim a little bit higher as I normally do, a little bit more on the adenoma. Now I do the same for the right orifice. There's the orifice, so I come back and I use this as a repair in order to open the bladder neck completely. Okay, so now the adenoma is already very mobile, so we're almost there. So as you can see, MiLEP is very possible in all these redo cases. Laser enucleation is known to perform very well in patients who are already treated for PPO, and with MiLEP, of course, this is also certainly possible. So this is the end of the enucleation. It's not so easy here to identify the plane. It's as you see, it becomes very thin. Luckily, the hemostasis is good, so there's no problem. But so now you see again this V-shaped incision. That's a very small perforation, so we avoid to make this larger. So you do that by cutting on the adenoma, by mobilizing all the rest and cutting on the adenoma. So very gently here, I lift the adenoma, and millimeter by millimeter I try to remove it, but I have to be very careful, again, due to the very thin prostate capsule there. See me trying to get some tension on the adenoma by lifting it and by removing it as complete as possible. So it's really step by step. I really make very small progressions here because it's so thin and fragile. But it's almost done. Okay, voila. The adenoma is completely enucleated. I have a look at the orifices and I check the hemostasis, but this looks quite good. The those thin zones in the capsule, they cannot really be treated well with laser coagulation. I think they can be left alone, but if they bleed, it's better to use electric coagulation for them if you have to do something about it. So this looks good, and we can go for morcellation. So that's it. Thanks for watching. Laser enucleation of the prostate is very versatile, and MiLEP can certainly also be used in the redo setting after previous surgery for benign prostate obstruction. Although these should not be cases that you attempt to do in your early learning curve. So thanks for watching again, and I would really like to thank my colleagues, the nurses and our administrative co-workers. Thank you.